Hi, I'm Vincent Rajkumar here with Dr. Shaji Kumar, head of the Mayo Clinic Myeloma Group. And Shaji, welcome. I just wanted to ask you, since I missed the EHA 25 annual meeting, I heard a lot about the RedirectTT study that you presented there with Teclistamab and Talquetamab for patients with refractory myeloma and extramedullary disease. Can you tell me something about it just to learn, and then maybe people who aren't there will get your insights on this important trial?
Thank you, Vincent. Absolutely. I think this is a very interesting study, primarily because it deals with a group of patients we all find very challenging to take care of in the clinic. And as we know, with patients living longer and longer, we are encountering more and more patients with this extramedullary disease. Clearly, a very aggressive variant of myeloma where the cells are growing independent of the bone marrow. And in the past, we have kind of mixed all these together where patients may develop a plasmacytoma that is contiguous with the bone. But where the biology is really different are those patients where the extramedullary disease is not just a mere extension of the bone disease, but truly independent of the bone marrow. Those patients we know already, even though it's uncommon in the setting of newly diagnosed myeloma, much more common in the relapse setting, these patients don't do very well. And we can treat them with all the different agents that we have, and we always end up with maybe some transient responses, but these patients eventually succumb to the disease. So very, very challenging group of patients to deal with. And certainly, compared to all the progress we have made in this disease, these patients really represent a significant challenge. So in the past, the clinical trials haven't really focused on this, primarily because these patients often have non-secretory disease. Almost half of the patients with extramedullary disease won't have levels of light chain or M protein that will meet the threshold for a measurable disease, and they are often excluded from clinical trial. The only way to really include them in clinical trials is to have a very stringent way of assessing response by serial imaging studies, which is sometimes not done in the context of larger studies for relapsed refractory disease. So clearly, we need to develop strategies that are very focused on patients with extramedullary disease. The question is, what strategy can we use? And we have seen that even though the responses are better with bispecific antibodies used individually or with CAR T cells, they are not still very durable responses. So this one of the so some of the inkling for what we could do differently came from the RedirecTT-1 study that was published in New England Journal of Medicine earlier this year, where the combination of Teclistamab and Talquetamab was used in patients with relapsed refractory disease. Almost 20% of the patients there had extramedullary disease, very similar to how we just defined. And in fact, about 60% of those patients responded to therapy, and the responses seemed to last for over a year. Now, armed with that observation, the plan was to develop a trial that was completely dedicated to patients with extramedullary disease. So the RedirecTT-1 phase 2 EMD cohort essentially enrolled patients with at least one extramedullary disease focus that was 2 centimeters or more, irrespective of whether they had measurable disease. And we enrolled 90 patients into the study. Interestingly, and the approach was to treat them with a combination of Teclistamab and Talquetamab, with the combination being given every 2 weeks after 3 step-up doses. Patients could stay on therapy for about four cycles of treatment, so 8 treatments given every other week. And after that, if they were in a VGPR, we could decrease the frequency to once a month. And after 6 months of treatment, irrespective of response, patients could go on to every month treatment.
Okay.
The primary endpoint for the study was overall response rate, again measured very strictly with using the combination of International Myeloma Working Group criteria, but implementing the need for imaging in a very consistent manner. So again, among the 90 patients enrolled, as we talked about, they had a median of 2 extramedullary lesions, anywhere from 1 to 7, visceral as well as soft tissue disease. And as we expect, 40% of those patients had non-secretory or oligosecretory disease. They were all triple class exposed by definition, But importantly, about 30% of these patients had been treated with prior CAR-T, an anti-BCMA ADC, or a bispecific targeting FCRH5. And what we found in this heavily pretreated cohort of patients was that the overall response rate was 80%, with a median progression-free survival of about 15 months and a 1 year estimated duration of response of over 65%. And again, the median overall survival was not reached for these patients at a median of about 14 months of follow-up. Now, to put these results into context, if you look at the Monumental 1 study looking at Talquetamab, the response rate was 43% in that patient population, in the similarly defined EMD population, and the CR rate was 15%. And the Teclistamab used alone in the Majestic 1 trial, very similar, 43% overall response rate, and the complete response rate of about 16-17%. Now, when you combine the two, now you're getting a response rate of 80%, twice as much, and a CR rate of 54%, which is 3 times as much what we saw. So there clearly seems to be some synergy that we are observing by using these two drugs in combination compared to just using them sequentially if you were to just follow the way the label allows us to do right now. So clearly, the efficacy, even in absolute terms, these response rates and the durability of response is more than what we have seen in the context of uh, uh, any of the treatments we can apply for extramedullary disease. Now, one might think, yes, it's definitely a lot more effective. Are we also seeing cumulative toxicity? The interesting case and the reassuring case is that it isn't. When you look at the overall frequency of adverse events, they're very similar to either of the bispecific used alone. Of course, we do see a fair amount of hematological toxicity. The CRS rate is about 70%. ICANS is about 12%.
Grade
And
1, 2.
mostly grade 1, not 2. And they are all seen mostly at the step-up dosing level, so the first full dose. So these are very comparable to what we saw with either Tecalon or Talcalon. And obviously, Talquetamab has some unique toxicities in terms of skin side effects, as well as the alterations in taste. But that percentage seems to be quite similar, even in the context of the two used together. Now, obviously, one of the other concern is infection, right? I mean, we have been really, and rightly so, concerned about infection risk with bispecific antibodies. Interestingly, we only saw about 22% grade 3-4 infections compared to the kind of the 30 to 35% that has been reported for bispecific antibodies. Now, it could be a reflection of the fact that these patients received therapy every 2 weeks and after 6 cycles went on to every month.
Mm-hmm.
So that could be a reflection of it because most of these grade 3-4 infections happened in the first 6 months. After that, the incidence seems to have kind of leveled off for these serious infections. So overall, from a adverse event profile, it seems to be pretty well tolerated. There were about 5 discontinuations because of adverse events. 3 patients discontinued both drugs and 2 patients discontinued Talquetamab alone. Most of these were for Talquetamab-related toxicities or infections. And there were, the interesting thing also was when patients switched to the monthly therapy, there was no significant reemergence of disease. There was only 4 patients who relapsed within the 6 months after the switch in the frequency of therapy. And the overall, the deaths that we saw, there were 10 deaths, 5 that were related to infections. 4 of them in the context of hypergammaglobulinemia, 3 with disease progression as well. And then amongst the 5 non-infectious deaths, only 1 that was caused by aspiration in the context of ICANS that actually could be attributed to the drug. Others all seem to be in the context of disease progression as well. So all in all, I think we have an approach that seems to be more promising than anything we have seen so far. A combination of 2 drugs that are both commercially available in the clinic right now, and which we seem to be able to apply without enhancing the toxicity, but certainly giving durable responses.
And where is this going now? Is it going for approval? Is it going to be available for patients and NCCN and things like that?
Yeah, for the NCCN guidelines already include the combination of the 2 based on the RedirecTT-1 phase 1 trial that was
Okay.
published earlier. So certainly it is a treatment option that we can potentially utilized today for our patients. Hopefully, this will move towards an approval. The strategy is to see if we can get regulatory approval to use this combination in this hard-to-treat patient population. Of course, the question is, can we extrapolate this even beyond EMD to plasma cell leukemia and all the other high aggressive disease biology situations?
Thank you so much. I'm sorry I missed the thing, but I think this is a great summary, and it looks like a good treatment for a really high risk group of patients that we are now more, like you said, it's becoming more common than
Right.
we ever used to have before.
Yeah,
Fantastic.
absolutely. Thank you.
Thank you.